productivity, it can be nice, this cluster metric can be a nice part of some of the regression modeling as well. So definitely great to see about all the GP work happening. As our title suggests, we're going to talk to you today about drivers of GP productivity. So, I can code, I cannot use clicker. I'm not sure what I'm doing wrong. Oh, here we go. So a bit about our team. So we are based in NHS England, and strategic analysis team is a multidisciplinary team of analysts, economists, behavioral scientists, who all work together on strategic projects for NHS England. We are a project-based team. Quite often we are demand-led as well, so we are being asked by executives or Secretary of State to look into things, and our work on understanding drivers of productivity is one of those. We are also trying to be proactive and horizon scanning some of the analytical questions, and of course we are focusing on patients and impact on patients with our work. So in terms of this particular project, I will start from a bit of a context, talk about productivity metric, and hand over to Sarah to talk about all the actual exciting things we are here for, such as all the data and all the methods, as well as results and what next steps can actually our work entail. So why does it matter? I feel like productivity is getting a bit of bad press at the moment, but it's also getting a lot of press, which is a good thing, because in a nutshell, productivity means producing as much output as possible, giving the input. In healthcare sector, things are a bit trickier. What is our output? So we are aiming to produce as much good quality care as possible. As Anita said in the keynote talk this morning, we are having increased needs, we are having increased demand. Unsurprisingly, people getting older, people getting more ill. We had a huge challenge of pandemic resulting in a backlog and waiting times pressures, which we need to address using productivity. We also are public sector, so again, we are trying to make sure we maximize value for all the public taxpayers' money. And speaking of money, we are not in an amazing position. Technically we're in a recession for a few months, and there are generally not as much money in the budget, so making every part count is important. And we do know a lot about NHS productivity, actually. There are amazing work by University of York and the Office for National Statistics. However, NHS productivity in non-acute sector is not as well researched. Hence, last year, we were asked by Treasury to look at how we can improve the way we measure productivity, including measuring it outside of acute sector. So what do we know? As I just said, ONS is producing some excellent annual estimates, and here you can see in the dark blue is the healthcare productivity overall. So they look at all the different activity, all the output NHS is producing, and looking at all the money it spends. You can see a few interesting messages here. One is between 2019 and 2010 and 2019, NHS actually was more productive than general economy. So there are kind of high expectations already here. However, unsurprisingly, because of pandemic, productivity really went down and hadn't quite recovered. There are some mixed estimates on whether we are at the pre-pandemic point or not. Going back to, okay, how then we can measure it. In a very simple economic definition, it's just how much output you produce divided by how much inputs you put in. Again, I believe Anita mentioned in the earlier session that cost-weighted activity is one of the things of looking how much care you produce. So you look at all the activity you do in the NHS and try to weight it somehow by value using cost as a proxy for value. And in terms of inputs, ideally it would be all the money you spent, but it can be specifically, for example, all the money you spent on workforce, which would give you labor productivity metric. However, GP world and wonderful world of GP data is totally different. One of the very important points is that high productivity is not always better. And this is something we are talking a lot with programs and policy makers about, because having appointments last 1 minute would be incredibly productive, but wouldn't actually deliver care, even if it looks quite good on the cost-weighted activity element. Also, and the GP care is supposed to be preventative, so you kind of want to do as little as possible, really. and also traditional metrics don't really capture the true value of care. And again, in the acute sector, we are somewhat lucky. We have a bit of a proxy for what care we produce, but in GP, we don't really know what's happening in the appointment. And data is generally much low frequency, more lagged. We don't know as much about NHS payments, as much about GP spend, so we have to use NHS payments to GP as a proxy, and Sarah will talk about it in more details. So there are loads of, I guess, analytical challenges as well. On this note, I will hand it over to Sarah to talk about our approach.
Thank you. So I'm going to talk through the approach to the productivity metric. So we start with creating our output, and for general practice, this is your appointment. So we're using the general practice appointments data set, and we're doing a few data kind of cleaning, wrangling steps. So we're starting with removing vaccination appointments. We're aggregating by financial year, and the recommendation for GPAD is to only use data after November 2017, so we're annualizing 17-18 financial year. We also apply a working day adjustment, and then we weight the appointment by the staff type who are delivering that appointment, and we assume an appointment duration of 10 minutes. Then we're creating our inputs, so we've got two key inputs. The first is total GP spend, and we're using NHS payments to GP data for this. And there's a field called total payments to GP practices, and this excludes COVID-19 and PCM payments. We deflate this by a healthcare price index. And then our second input is labour spend, and this uses GP workforce data. And we're taking the labour full-time equivalent and weighting this by the salary for all the job roles. And then we're selecting practices that have over 1,000 registered patients. And then to bring this all together into our productivity metrics, we're linking our outputs and inputs by financial year and the practice code. And then we've got two separate metrics. So the first is for total factor productivity, and this is using our total GP spend input. And then our second one is labour productivity, using our labour spend as its input. And both of these are using 2017-18 prices. And as Anastasiia has pointed out, each of these productivity metrics is a ratio of your outputs over your inputs. So just to show what these two metrics are telling us, we've got a time series here starting from 2017-18 up to 2021-22. In dark blue, we've got the ONS, overall NHS productivity growth. And in grey, we've got our general practice labour productivity growth. In light blue, we've got the general practice total factor productivity growth. And what we're seeing here is we've got some growth in general practice from 17-18 up to 19-20. And then we've got a decrease in growth around the pandemic that's similar in the overall NHS productivity growth. But this is impacting general practice less than overall. And then the other thing to point out is the variation that we've got in these metrics. So we've got productivity along the bottom and density on the y-axis, labours in blue, and total factor productivity is in grey. And just to say, there's high variation that we're seeing between the practices. And we can explain this by data submissions, practice mutual aid, the way that activity is recorded, but also this is showing some variation that we're seeing of how many appointments a practice can actually deliver per one unit of the input. So now I'll explain our approach to the regression. So we've constructed a GP level panel data set, and we're using annual observations from 2017-18 to 21-22. And because of data quality and inconsistency, we're removing outliers using the interquartile range rule, and this gives us a final sample of about 30,000. And we're estimating two separate models, one for total factor productivity, one for labour productivity. They're very similar in the fact that we're modelling the impact of things like workforce characteristics, practice characteristics, and also population characteristics on these two metrics. And we're employing a two-way fixed effect model that accounts for individual and time effects. We've also done some cross-sectional models where we've got data drivers that only have a snapshot of data rather than the full time period. So what hypotheses are we testing in our regression? For general practice, we've considered both internal and external factors. So things like workforce characteristics, practice characteristics, population characteristics, and also the wider system. I'm not going to go through all of these because we'll get to them in the results, but these light blue boxes are the factors we've been able to test in the model. And we're definitely aware these are not an exhaustive list, so all of these other ones in white boxes are other things we've considered but we've not been able to include. So for example, we've got sickness absence within workforce characteristics. We haven't got data on this and not been able to include. Also, we tried to look at technology within practice characteristics. So we're trying to work out the proportion of IT spend. The data quality was too difficult to include on that. So now to the results. Just to say up front, the arrows are representing variables that have a significance level of at least 10%. So if we start with the practice workforce factors, admin to GP ratio showing us a positive association for both types of productivity. So this could be that more admin staff is reducing that admin burden on your GPs. They can have more time spent on appointments, increasing your outputs, increasing your productivity. And then we've got the complete opposite result for nurses to GP ratio. So this is likely to be because we're cost weighting our activity. So an appointment done by a nurse is weighted less than an appointment done by a GP. And this is a really good example of why these productivity metrics are not really showing the real value of productivity. And then direct patient care staff to GP ratio, we're just seeing that negative association for labour productivity. This is likely to be because GPAD isn't capturing all of the activity that we know this staff group is doing. So we're probably not seeing the full outputs of that staff group. Then we've got proportion of GPs in training, also showing a negative effect with labour productivity. GPs in training will need time for training. They will maybe take longer on appointments, so your output's going to be lower, and that's maybe why we're seeing that effect. The proportion of GP locums, this could be kind of twofold. They're a more expensive staff group, so that's going to increase your inputs, but also because they're temporary staff, they may take longer to get a handover or things like that, so their outputs may be lower as well. And then we've got weighted average age of GPs, and we're using this as a proxy for GP experience, which may not be the best, but this is kind of the data that we've got available to kind of have an approximation for this. And we're seeing a negative association for both types of productivity. And for labour, again, this might be because a more experienced GP is going to be a more expensive staff group. But it's less clear why on total factor productivity we're seeing that, so that's something to look into. And then for practice characteristics, we've got the proportion of remote appointments showing a positive association for both types. Remote appointments are typically going to be shorter. You're not going to do the same kind of examination that you can do face-to-face. You can have more appointments, more output, more productivity. Then for out-of-hours practice, we're seeing a positive association for labour productivity. This is going to be because you've got the same number of staff, but they've got extra appointments that they're going to be able to do because you've got extended hours. We're not going to see that effect showing up for total factor productivity because the GP should be receiving additional funds for those additional hours to kind of balance that out. And then practice size, we're using patient lists for this, is showing a positive association just for labour productivity. So this might be because a larger practice can employ more staff and benefit from the economy of scale, but we may not see this with total factor productivity because you should be receiving more money for a larger patient list. And then for population characteristics, we've got the proportion of appointments where you've got did not attend. So unsurprisingly, this is showing us a negative association with productivity. Do not attend appointments are not going to be included in your output, so you've got less output. Then the proportion of patients who are aged 65 plus is showing a positive association with both kinds of productivity. So this had a really strong correlation with the proportion of your population that has long-term conditions, which is from the Bridges to Health data set. And we had to remove that from the regression because of multicollinearity, but it's kind of helping us to see that maybe this proportion of over 65s are having more routine appointments, so things like a cholesterol check, blood pressure checks, things like that. They could be shorter appointments and increasing your productivity. And then the next four I'm going to group together because we've got the same negative association with total factor productivity. So this is looking at the proportion of your population with disability, frailty and dementia, organ failure, and then also this last one of patient deprivation, where we're using income domain score. And I've grouped them together because we have a hypothesis around general practices receiving funding based on the health of their population. So this might mean that they are receiving additional money, which is increasing the inputs for your total factor productivity. But again, this is worth looking into why we're seeing that. And then finally, we've got proportion of patients who have a preferred GP and saw them. And we've got a positive association for both types of productivity. And so this is kind of commenting on continuity of care. You're going to be more efficient with appointments if you don't have to keep explaining your symptoms to different GPs. And then one other extra thing to add about the cross-sectional models that we've done. So we've looked at the estates data, which we've only got a snapshot of data for. So things like ownership of the practice, rent reimbursement, and building age. And what we've seen is that there's a negative association that's significant between rent reimbursement and productivity, but this data is quite experimental and has a lot of missing data. And the same model also showed a negative association for practices that have a dispensing status and productivity. So potentially we're not including that activity that they're doing for dispensing in the metric, but potentially it's kind of reducing their ability to do the activity that we are capturing. And then just to wrap up the practical implications and next steps of this, so the data quality and data availability that we've got are definitely showing that our metric isn't showing true productivity, and we aren't analysing the trade-off between quality and productivity. So we definitely want to improve the existing metrics, look at alternative data sources, investigate the pathway approach, and work on improving our existing data sources like GPAD. And we also want to understand quality and productivity. And quality data is limited, but we'd like to do further analysis to understand links between general practice, patient satisfaction, and productivity. Thank you very much. That's all from us.
Are you ready for questions? We've got quite a few come through. If we don't answer them all, we will catch up with you afterwards. Just to remind everybody that Slido is available to also uptick questions that you'd be interested in being asked, and the number is 3716942. I am just looking through because there was a couple of questions that got a bit muddled up in Slido. So I'm going to just read them as they came in. How do you account for geographical differences, costs, etc.?
Well, because we used fixed effects, in theory it should account for individual effects of each practice, which is kind of accounting partially on geography, but we have not done any additional, well, we could use random effects and have an additional metric of region as well, but we haven't done it at this stage.
Noting the impact of nurse, GP in training and use of locums, do you think this analysis is relevant to current policy decisions regarding restoring the family GP?
Oh, that's an interesting one. I think, yeah, so as Sarah said earlier, I strongly believe that NEOR's result is one of those that just highlights the imperfection of the metric and imperfection of the cost weighting approach in general. So I think I would not go as far as using it for policy implications just yet. But I think the variable of having a preferred GP and seeing them, I think that's the interesting one, because if it is a true effect, then there is all this element around it actually can be productive to see preferred GP, which family doctor would be. So I think there is definitely room to inform those sort of policy implications as well.
Could the reason DPC decreased productivity be because of the burden on GPs to manage these staff, for example, supervision?
I mean, it can be. So direct patient care, you haven't really explained it, all additional roles, such as people like dietitians or people like physiotherapists. So I guess in theory, yes, it does kind of expand GP's responsibility. I think it can be an issue, but I do wonder whether the fact that it's only in labor and not in total factor productivity suggests that it's probably more to do with the way we count it in denominator, but not in the numerator. But again, would be good to explore. Definitely, we'll take it on board.
Some of the factors driving productivity, practice size, remote consultations, could be driving lower continuity of care. Could an excessive focus on increasing productivity damage quality of care? Yeah,
this is one of the other things. Kind of pathway approach here is hiding what in ideal world we would do is if we had GP data similarly to SAS data we have in acute sector, we would know how many people, how many patients practitioners are seeing, and then you could argue, oh well, yes, your remote appointments showing like you have a lot of activity, excellent productivity increase, but actually following this remote appointment, pathway of care shows how patient has to go to GP, probably with more deterioration, or even if you look at the whole system analysis, has to go to 111 or A&E. So yes, there is, again, that's why we are really asking you to take this whole results and approach with a pinch of salt, because yeah, we want to look at the quality as well and patient satisfaction.
I think that's everything on the questions. I'm just double checking just to make sure you're really ahead of time. If there are any more questions, please do go to Slido 3716942. I think you've gone through all of them that we've got. So thank you so much.
Oh, there is.
Oh, one more. Go for it. Do you want the speaker? Come here and do the speaker.
Sorry. I must have gone quick.
Talk to the speakers. The question I've got relates to the last thing you just said, which is what's the relationship between productivity and quality? So a long time ago, in 2010 I think, what was then called the Information Centre published a set of NHS-wide metrics at the GP practice level. So you could measure, if I remember correctly, hospital admissions, GP, A&E attendance, A&E admissions. I think you could do mortality at the practice level. Would a full set of metrics like that help understand that relationship between quality and productivity? So we're actually measuring what we want the GPs to do, improve people's lives, improve the quality of the system.
Yeah, I think 100% could. So we had quite a few colleagues actually working with us as well. Henry Dowell in the team looked at the quality, and we identified a couple of domains of quality. Absolutely rightly, something from NHS outcomes framework or quality outcomes framework could be part of it, but also satisfaction was one of the domains we identified, and patient safety, which we don't have data for, but we have patient complaints data. So I think definitely that we have data for QOF, safety, incidents, and satisfaction in the data ready to kind of get analyzed as well as part of regression, as part of descriptive, but I will definitely look at this additional data set as well you mentioned. I think it would be extremely important, and ideally it would inform as well how we can adjust for quality when we develop the metric, because you would want to have quality adjusted productivity similar to what ONS and York are doing. Thank you.
Thank you. Got a couple more questions, if you're okay for a couple more. Would it be possible to track the number of appointments a patient makes? If a patient makes multiple appointments, this could be a sign of poor productivity, particularly thinking about this with regards to virtual appointments.
Yeah, all we have is we aren't able to follow the patient, because that would be very helpful to know how many times. But yeah, we don't have the data for that.
And did you think about using a data envelope analysis?
Oh, I feel like that's a question from Stephen. No, we have not, but luckily other people in NHS have done, and research unit report about it. I mean, it would be excellent, but we wanted to create something relatively simple, go for a ratio, something we can work with programs and talk to them about why we need something more sophisticated, essentially.
Well, Well answered. Thank you so much for your wonderful